Vanakkam everyone, this is Dr. Priyadashni and I welcome you all to another Fatafat lecture. Today we are going to learn topics from general surgery, that is carcinoma of thyroid gland. Carcinoma of thyroid gland majorly classified into four types, that is papillary carcinoma, follicular carcinoma, anaplastic carcinoma and medullary carcinoma. We are going to learn these topics under few subtopics like etiology, age, prevalence, investigation, spread, histopathology, treatment and prognosis. So let us start the lecture. First of all, etiology. Etiology for papillary carcinoma is irradiation. If the patient has already exposed to the radiation before the age of 5 or he or she is under exposure of the radiation continuously, they might have the high possibilities of developing papillary carcinoma. And for follicular carcinoma, it is endemic goiter. If the patient already has goiter and the goiter may develop as follicular carcinoma. For anaplastic carcinoma, there is no particular etiology, but in some books they have given like it may develop de novo or it may de-differentiate from the papillary carcinoma. So for medullary carcinoma, it is familial or sporadic. In most cases, sporadic is the major cause of medullary carcinoma. Then age. For papillary carcinoma, it is 20 to 40 years of age. Already we have known the etiology. It is said that for exposure under 5 years of age, so patients or the carcinoma will develop in patients in 20 to 40 years of age, and for follicular it is 30 to 50 years, and for anaplastic it mostly affects the old age people, so it is age greater than 50 years, and for medullary it is middle aged people, MM, so you can remember like that. So age of occurrence is 20 to 40, 30 to 50 and more than 50 and middle aged people. So prevalence is papillary carcinoma is the most common kind of carcinoma. So it is 80%, and most rare is anaphylactic or medullary. It is the percentage is given different in different kinds of books, but I have referred Bailey and Love. They have given 5% for anaplastic and medullary it is 2.5%. So according to that, it may differ. The anaplastic and medullary may differ in the rarest form. So for follicular it is 10%. Next comes the investigation. Investigation on palpation or visual observation. Thyroid swelling is present commonly in all kinds of carcinoma. So along with those findings, there are particular findings for each carcinoma. So for papillary kind of carcinoma, there is swelling with lymph node involvement. If you are going to palpate, there will be swelling extending to the lymph node itself. So that is for papillary carcinoma. And for follicular carcinoma, there is bony metastasis is present. Okay. And for anaplastic carcinoma, there is local fixity. The swelling or the carcinoma is fixed to that local area and it is not movable. It also causes stridor, that is patient has difficulty while breathing. So for anaplastic it is thyroid swelling with stridor and local fixity, and for medullary there is no common actual finding. In some cases the swelling itself may not be seen prominently, and for diagnosis the FNAC, fine needle aspiration cytology, is done for papillary, anaplastic and medullary carcinomas, but it is not done for follicular carcinoma. It is because that in follicular carcinoma we cannot differentiate from malignant and benign type. If we do FNAC, we cannot differentiate both. So frozen section is done for follicular kind of carcinoma. After that, metastasis or spread. So already we know that lymph node involvement is seen in papillary kind of carcinoma. So carcinoma is spread to the lymph nodes, and for follicular we said that there is bony metastasis. So follicular carcinoma usually shows distant metastasis that it is spread through blood. So for anaplastic, there is local infiltration. There is local infiltration for anaplastic carcinoma, and for medullary, it is lymph node and blood. So both the medullary, this carcinoma uses both the lymph node and blood for metastasis. So histopathology, for papillary carcinoma, it is somamobodies. You can see the spelling in the tabular column I have shown, or you can refer the book. So somamobodies is somamobodies is seen in papillary carcinoma. Sorry. And for follicular carcinoma, it is angioinvasion or capsular invasion is seen, and for anaplastic, it is poorly differentiated cells. That is, I have already said in the etiology itself, it is de-differentiated from papillary carcinoma. So the cells are poorly differentiated in the anaplastic kind of carcinoma. And for medullary, there is amyloid-like stroma is present for medullary type of carcinoma. And we are going to the final part, that is treatment and prognosis. Treatment is thyroidectomy, obviously. So near total or total thyroidectomy is done for papillary, follicular, anaplastic and medullary type of carcinoma. But according to prognosis, anaplastic carcinoma has worst prognosis. So even we do the treatment also, there are very less chances of the patient to survive after the treatment. So likewise, even if we do not do the treatment also, the patient is going to die. Or if we do the treatment also, the patient is going to die. So the prognosis is very worst for anaplastic, and it is bad for medullary, and the prognosis is excellent and good for papillary and follicular type of carcinoma. So this is all about carcinoma of thyroid gland. If you have listened to the lecture fully, let us have a fatafat Q&A. Let me know the answers in the comment section. Okay. First, what is the etiology of papillary carcinoma? Middle-aged people are affected in which type of carcinoma? What is the etiology of anaplastic carcinoma? Which is the most rarest type of carcinoma? Thyroid carcinoma, most rarest type of thyroid carcinoma. Histopathology finding in papillary carcinoma. Amyloid-like stroma is present in which kind of carcinoma? Etiology of follicular carcinoma. FNAC investigation is done for all types except which carcinoma has the worst prognosis? Anaplastic carcinoma spreads or metastasis through papillary carcinoma has dash prognosis. So let me know the answers in the comment section. Thank you.